So anyway, let's go on to the subluxated cataracts.
Mm.
And to begin with, one thing is that when you are doing a pre-operative examination, you need to know why the cataract is subluxated. So the etiology part is very important. Why so? Because there would be situations where this subluxation may be generalized, like a hypermature cataracts. There would be situations where it would be progressive, as in pseudo exfoliation. So you may have subluxation in one quadrant, but eventually after doing a surgery the patient may continue to have increasing subluxation, and there may be a situation where the patient comes up after years with the entire IOL and everything into the vitreous. So you must identify what you are dealing with, and there would be patients of ectopia lentis who have presented late, and these ectopia lentis patients, there may be subluxated, but the remaining zonules are usually quite stable. So these are the different situations. And the other thing is, many of these patients like Marfan syndrome, these would have a predisposition to development of retinal detachment. So you have to not only check these, and there would be other congenital malformations, like there may be you need a complete cardiac evaluation, because during anesthesia the patient may have a problem. So once you get a patient of subluxated cataract, your planning starts well in advance, not only as to what kind of procedure you're going to adopt, what kind of device you're going to use, but how you are going to manage the patient pre-operatively and post-operatively. Now, the other thing that you have to keep in mind was that before you start the surgery, you say it's 3 clock hours, 4 clock hours subluxation. But when you actually start the surgery, you may realize that the subluxation is far more than what you were actually planning to do. So it is always to keep the complete set of devices. I always keep a CTR, a capsular tension segment, and a scleral fixated lens standby for all my patients with subluxation. So you talk to the patient and say that you're going to return rest of the devices, but on table you may have to change your plan. So these are the different commonly used devices. The CTR, that is the capsular tension ring, I had shown in the previous surgery also, and that is one thing I think all of us must have it in the OT, always readily available. Then of course these are the CONE devices, that is the modified CTRs, where it has a hook which is at a level of your ciliary sulcus. So it is above the capsular bag. It is not within the bag that this eyelet is placed. Now there can be single CONE or there can be a double CONE. And these devices, the disadvantage, I used to use them quite often, but the disadvantage is these are very bulky devices. These are made up of PMMA, and while inserting these devices, there was lot of zonular dehiscence, and so eventually I have actually started, I don't use these CONE devices any longer. Instead of that, you can दोनों अच्छा. Instead of these devices, you can actually go in for capsular tension segments. These are very small devices, and there is an eyelet over here, and they are made Indian manufactured, very cheap. So you can use this eyelet for this purpose, and you can combine it with the CTR to stretch the back. And since it is very small device, it is very easy to insert. It does not injure your zonules while inserting. So I have totally given up all my CONEs to CTS with CTR. Now, if you need to, stabilize your bag at two areas, you can put in two capsular tension segments instead of one. So let's go and see the videos now. एक मिनट देखना, इसका वो वाला वीडियो साथ वाला है कि नहीं, चल क्यों नहीं रहा. उसका फोल्डर में वीडियो डला हुआ है कि नहीं, कभी उसका
फोल्डर, लुक इन द फोल्डर.
नहीं तो मेरे पास पेन ड्राइव है उसमें. हाँ ये होना चाहिए. या आई थिंक. So you can see the here, this was a patient of post-traumatic cataract with about 4 cloacas of subluxation. So I was wondering what to do, whether to go in for a CTS and fix it up or just do a CTR. So now whether to put in a CTR before you remove the nucleus or put it afterwards. You can put it beforehand if you feel that your zonules are very unstable and it is difficult to complete the surgery. You see there's a large subluxation, so I decided to put the CTR beforehand. The problem of putting it beforehand is that it becomes very difficult to sometimes remove the cortical pieces. Now this is another patient where there is a trauma and you can see the entire capsule is also ruptured. So the mandatory requirement for all these devices is that your capsulorhexis has to be intact. So what I did was I created a capsulorhexis in an area which is away from the area where the entire capsule was torn. I completed my capsulorhexis, and of course nucleus management I have not repeated again and again because it is done in the similar manner. And after this you can see this is a partial thickness scleral flap, and here I have used a Sioni, and this you can see it's a very bulky device, and this eyelet was fixed over through the suture. Like in a scleral fixation, you tie on the suture, the proline, ninoproline has been sutured to the eyelet and it is brought out through these exit points over here, and you tie them just beneath the partial thickness scleral flap. So, and after that, instead of going in for a PMMA lens, I have gone in and injected the IOL right into the bag, because remember here the capsulorhexis is small in size, so I don't want to fiddle with it. This is another patient where there was a large subluxation and it was almost more than 180-degree subluxation, and see I have used these are the iris retraction hooks which has been used to stabilize the bag, but that got I think edited. The point was that after doing everything I actually had to go in for scleral fixation. So sometimes you need to see if it's a very large subluxation, don't waste your time, and you can directly go in for a scleral fixated lens. I'll just show you some one more video where there is a large subluxation. एक मिनट आपको करना पड़ेगा जरा, कहाँ पे है अदर वीडियो, पीपीटी चला दीजिए उसमें खुल जाएगा. हाँ okay, so this is a more than 180-degree subluxation. So what do you do here? If you try to fiddle too much, what will happen is there is a chance that this whole lens and everything may fall back. So what I have done is I have already planned to do a SFIL. There is no point when if your subluxations are very large that you keep fiddling. So it is better to do a cleaner surgery, and before opening the wound it is better to dissect these flaps, because once the wound is opened the eye becomes so hypotenuse that it becomes difficult to dissect these flaps. The other important point is that you must do a very good cauterization, because if you leave a bleeder over here, when you are trying to do your subsequent maneuvers, this bleeding would trickle down. It will cause a post-operative vitreous hemorrhage, and the patient is very unhappy if there is the vitreous hemorrhage takes very long to resolve. So you can very well avoid this. Do a very good cauterization when you are after you have dissected your flaps. And now I am going to put a infusion cannula. So this is a 20. Yeah, this is the infusion cannula which is placed 3.5 millimeter from the limbus, and you can connect it to the. This is the infusion being connected. So the advantage is this is going to push the nucleus up and it will prevent it from going down, and at the same time it will stabilize my chamber. So now before opening the wound again, see I have passed my straight needle nasally, that is 1.5 millimeter from the limbus, and this is the 26 gauge needle temporally, and then I open my wound. Having done all these things, my chamber, the hypotony would be created now. So this infusion cannula can be put on at this time, and this you see with the fluid it was very easy to prolapse the nucleus out. Then you of course you need to do a good vitrectomy to clear the vitreous, because This is the vitrectomy being done, and you can actually put off the infusion cannula at this stage because you have a infusion. And here the side port has been with through the air has been injected, and this I have not injected viscoelastic at all. This needle is docked into the 26 gauge needle and it is brought out. And this suture, this is a 26 gauge needle bent, and this proline suture is brought out. It is divided into two parts. The IOL is tied, and this is Dr. Malik's technique of burying these suture knots, which I'll be showing subsequently, where none of these sutures, there's no suture erosion in any of our patients. So this is the usual SA file technique. After that, this IOL is placed. The two sutures are pulled, and all the maneuvers have been done under either fluid or air. So we have realized that if you don't inject viscoelastics and they don't mix up with the vitreous, there is less reaction vis-a-vis when you use a lot of viscoelastic, everybody has a tendency of pushing into the vitreous. Now this is a teno suture. A bite has been taken from the bed of the partially dissected scleral flap. It is tied onto itself, and the same suture is then tied to the exiting proline suture. So this secures the IOL in place. Of course, there are multiple ways of doing a SFIL, but this has worked, and I have seen his cases now with 40 years follow-up, and my own cases with nearly, I think, 25 to years follow-up, and they do very well. So this is a bite has been taken from the posterior surface of the partially dissected flap, and this we have published in I think Delhi Journal of Ophthalmology. So this really helps in burying this suture knot very well. And this is the area where there was the sphincter had was damaged, so I'm doing a pupilloplasty. So all these patients, as I said, you have to work out what is going to fit in. Not one technique is going to fit in all cases. And this is the McCallan suture, which I think all of us are using. This is just the same needle, the remaining portion which of the proline suture which was left, I have used it for repairing the iris. And after that also, if you feel at any point of time that your flap is not very well buried, this partial thickness flap, I routinely now also put a suture. The conjunctiva, I just give buried 8-op vicryl suture, so that there is no exposure at all of these patients. Now sir, time hai ki band kar दूं?
बहुत टाइम है.
अच्छा. So this is another interesting case of
we have time for discussion anything, but if you want something, what you're talking?
I'm talking about the coloboma part now.
Coloboma, do it.
Okay, so lots of times you may have patients where you have, it's not just the subluxation, there may be other malformations associated. So remember, always look for a lens coloboma in these patients, because what happens is, if you can see this picture, there is a lens coloboma over here. There is no capsule over here. It's not only broken, the capsule does not exist. So that is a difference between these patients and your regular subluxated cataracts. So in these patients, I'll just show you what the problems I fared. Let's see if the video is there, or okay, one video is there. So this is an older video, and here I had planned to put in a Sioni. So I had already created a partial thickness flap, and I was planning to do an SICS. So you see, I am trying to hydro dissect, and however hard I may try to hydro dissect, the fluid wave is not dissecting at all, and the nucleus just failed to rotate. You see, I kept on dissecting, there was no way the wave would reach that area. So these patients where the capsule is actually missing in that area, it's a kidney shaped capsule in that area, there this technique of trying to put in and trying to rotate the nucleus is not good. So finally I had to actually convert it into an SA file. The second eye which I did, we have published it in this you can read the complete article. The second I was wiser. What I did was, instead of, I realized that the nucleus will not rotate. So what I did, I shifted it to phacoemulsification. I did a in the bag debulking of the nucleus and then took it out, and then I implanted the IOL. So that worked. So the point is that not all patients are going to fit into your standard. There is no like, if you have to do this algorithm that this will work in this, you have to see every patient in totality before you decide what you want to do, especially in patients with lens coloma. If you want to do SICS, only go for hydrodelineation first. Maybe you can take out the nucleus, nucleus. Otherwise, if you're just doing hydrodissection, it may be difficult to rotate the nucleus. So you remove the center core, core of the nucleus, go in for aspiration later on, and then put in the IOL. So these are small little things which I have experienced in my practice. And of course, this is the standard teaching that if it is up to 4 clock hours of subluxation, you can go for CTR, but provided your remaining zonules are intact, they're they're not weak. If there is a generalized subluxation, even small 4 clocks of subluxation, I would not go in for a CTR. I would rather go for an SFIL or a CTR with a CTS. So anyway, between 3 to 6 clock hours, of course, you can go for a modified CTR. Nowadays, as I said, I think that going in for CTS with CTR is a choice for all these patients. And if the subluxation is more than 6 clock hours, or let us say more than, let's say, 7 clock hours, I would rather go in for SFIL directly rather than struggling and making a mess. You end up with a cleaner outcome with those in that case. Thank you so much.
Thank you very much.